Well, I just didn't want to launch in and go
No,
and
no.
if you like
I
prepared a whole bunch of stuff.
I feel like most of us watching this and participating really have neurophobia, so I'm excited for this week.
It's a great
Oh,
word.
maybe I should have done more prep then. Um, so I feel like I was kind of like, because I'm going around, like, this is my third time through Edinger doing these tutorials. So I'm kind of like, oh no, we've done that, we covered this, haven't we? But it's like it's a different group of people. So we'll just start from the beginning.
Sounds
So
good.
is there any specific neurophobia that you would like to make sure we cover?
Oh, that's a great question. No, I don't think so. I think localization should hopefully cover it. I quite
Mm,
like the internal medicine approach because I feel like it's really practical, which
mm,
helps in general practice to not get
yeah.
really overwhelmed.
Yeah. Yes. Yeah, we're definitely not neurologists. That's for sure.
Right.
But it is nice to just be able to say, this is outside my remit. But here it is.
Can you can you
um,
define a neurophobia? Are we talking about storm phobias?
no.
That's
Um,
what you're no.
no, I
We're
just don't
we're
want.
afraid of neurology.
Yeah.
Oh, I see. It's referring to the vets. Okay, got it.
Yeah.
Yeah.
Yeah. Human neurophobia.
Yeah.
Because it is really overwhelming, right? When a patient comes in, like, clearly neuro, but then you sort of like, oh, I don't know even how to guide the owner. You know, they might say, I don't want to go for referral unless it's got a good prognosis, and you're like, oh, I don't know.
My biggest
Um,
phobia is that I'm going to miss something lower motor neuron and and think it's spinal and send it to the surgeons or put it in the MR. That is my biggest phobia.
I was going to say the same thing, and I
mm,
should know it, but upper motor neuron versus lower motor neuron, and it's not always as clear cut as it should be.
Definitely
Mm.
not. And I've had this so many times where as a clinician in a referral setting, you get sent something that's progressed further than when the vet looked at it themselves.
Mm.
And I've so often gone, oh, it's clearly lower motor neuron, but then had the vet with me go, I did that and it was not yesterday. Like that's
Mm.
so you sort of learn that particularly as a GP, if anybody's like a first opinion person watching this, where you're seeing them is when they're not as progressed as when often they've decided to go for pursue referral and stuff. So don't judge yourself. It's impossible sometimes. It doesn't present itself. It doesn't go reflex on, reflex off. You know,
Yeah.
it's a path. Um, so where you get the report back and go clearly no lower motor neuron, like don't be mean to yourself about missing it. It's just that it probably wasn't there at that point.
Yeah. Yeah.
Um,
Okay.
okay, so the other thing I'll say before we kind of like go deep into neurolocalization is that a lot of neuro diseases are multifocal,
Mm.
or there might be like lumbosacral degenerative disease, which is skewing your neuro exam.
Mm.
So there's a lot of different reasons why neurolocalization is not an exact science and why you might end up running a lower motor neuron dog through the MRI or vice versa.
Yeah.
So again, just have an open mind and think, oh, it could be two things. Might be multifocal. Could be two things. Could be
Mm.
anything. Somebody help me.
Yeah.
um, okay, let's talk about first. What are the regions that we're neurolocalizing to?
Forebrain,
Yes, great,
brainstem, cerebellum,
great, great, great.
And then
and
spinal
then the
cord,
spinal
Mm-hmm.
segments.
Yeah,
and then peripheral nervous system.
Mm.
great. Low motor neuron, exactly. So spinal segments. Well, how do you divide them up?
Are you gonna?
C1,
Yeah.
C1 to
I'm. You
C7.
go.
The moment
You
you
want to
go.
go C7? to T13, T13 to L2, and L2 or L3, L3 to L7.
Yes,
No,
that's
I've got
how
it
we
wrong.
divide up. No, it's not wrong. It's kind of how we divide up the sections of the spine in the way that we think about them. But actually, neurolocalization wise, we can only localize to stretches where the nerves kind of don't come out in that section. So the localization typically goes C1 to C5 because at C6 we start to get the thoracic limb nerve roots coming out. So then all of a sudden, if we can get a lower motor neuron arc or lower motor neuron sign, if we've got a C6 to T2 localization.
Mhm.
Yeah. So C1 to C5 and then C6 to T2, so it's quite narrow. And then the next one is huge. So you sort of think of it like thoracic vertebrae, lumbar vertebrae, but actually it's T3, L3 before anything really comes out of that spine. So it's a really big stretch. And then L4 to S3, where all those, again, like the lower motor neuron nerve roots to the pelvic limb come out. So our sections are C1, C5, C6, T2, T3, L3, L4 caudal, basically. And that's important because we're going to make a call on whether this could be spinal or whether this is lower motor neuron based on where those nerves are coming out, and that we know that those nerve roots might be impacted by a central lesion or a spinal lesion at that level.
Yeah.
So we might do a few cases later on and just sort of like pick at that a little bit and just sort of say, okay, this is, is this lower motor neuron or not? And does that make it a lower motor neuron disease or can it still be a spinal disease? The only other localization that's probably worth putting in there is vestibular, which is probably technically brainstem, but it's such a specific localization, right? Like nothing else presents like that. So I'll just chuck that in there as well. If we sort of think forebrain, brainstem, cerebellum, spinal, lower motor neuron, or vestibular. I do really like physiology. Does anybody else really like physiology?
Which organ
I
system?
don't dislike it. I don't understand it.
So I would love to talk about the neurotransmitters and how they incite change on their postganglionic receptor, if that's all right with everybody. But first I want people to tell me what broad sections of the nervous system, so we've done neurolocalization, I'm not talking about like the anatomy of the nervous system, but what, how would you divide up the nervous system in terms of function?
Sympathetic and parasympathetic.
Yep. What's doing the muscles?
Sensory and motor.
Yep. So parasympathetic, sympathetic are your autonomic nervous system.
Mm-hmm.
So we've got no forebrain management of those sides. What's the part of the nervous system, the other side of the nervous system, which is under conscious control from the brain?
Just voluntary.
Yeah.
Voluntary, I can't think of another name for it.
Is it somatic? Is that the... I can't remember the name now either.
Well, it could be somatic and visceral, I guess. So, yeah.
Yeah, somatic is all conscious as part of your peripheral nervous system. So that would be your sensory and motor, like Jill said.
Yeah. Oh my gosh, what's it called? Yeah, motor and sensory. Good. We know what we mean, but I want you to just have in the back of your mind that there's two different branches of the nervous system. There's the branch that's under motor control, and there's the branch that's like automated and runs all our autonomic functions. So if we look at the sympathetic nervous system, what's its role?
Fight and flight.
Mm-hmm. Good. And what is the key neurotransmitter in the sympathetic nervous system?
Acetylcholine.
Good. Acetylcholine.
Adrenaline, sorry. Noradrenaline.
Good. So you're right. So there's a preganglion fiber, and there's a postganglion fiber, and then there's the neurotransmitter on the end that goes to the muscle. So the preganglion, the first nerve, the neurotransmitter is acetylcholine, and the second nerve is adrenaline or noradrenaline. So their neurotransmitters are slightly different, depending. Oh, hang on, am I got that right? Yeah, no, that's correct. So all preganglionic fibers are acetylcholine, both parasympathetic and sympathetic. Postganglionic are adrenaline and noradrenaline in the sympathetic. What's parasympathetic's main neurotransmitter?
It's acetylcholine, isn't it?
Great, excellent. And what receptors do they work on?
Nicotinic or
Very good.
Muscarinic.
Good, very good. Why is that relevant? Why do I care?
This is only parasympathetic we're talking about now, or you're talking about both?
I'm talking about mostly parasympathetic here.
This is delving
probably
into
care
stuff
because
I
that's
did
how
30 years ago. I don't know.
that's how a lot of drugs work. That's probably why we care.
Yes. What's the mechanism of action of atropine?
Blocks acetylcholine. Blocks atropine.
Which receptor? Nicotinic or muscarinic?
I think it's a nicotine.
Muscarinic.
So what effects does atropine have?
Increase the heart rate.
Yes, excellent. What else?
Dries up mucous membranes, so it
Good.
stops secretion of things. So
Good.
I still don't know whether it's muscarinic or nicotine.
It's muscarinic.
So it's because it's anti-parasympathetic. That's kind of how I think of it.
Yes, excellent. So that's where I was going with that. So we can work out, based on our clinical knowledge of what atropine does, that atropine inhibits the muscarinic acetylcholine receptors.
Mm-hmm.
It inhibits the parasympathetic nervous system by inhibiting salivation, lacrimation, urination, defecation. Doesn't it? SLUD, remember that? And therefore it's inhibiting the parasympathetic nervous system. So then we know parasympathetic nervous system acts on muscarinic receptors normally. So we can upregulate that and cause salivation, lacrimation, urination, defecation. What drugs do that, or what toxins might do that? There we are.
Things that stop the ACH esterase. So there's more ACH in the junction.
Yes, yeah. So
what about snail baits, those kind of things?
Yeah.
So there is one type of snail bait, if you're presented with a snail bait toxicity, that is a muscarinic receptor agonist, and you can reverse that with atropine. So it's actually atropine is actually an antidote to certain types of snail bait toxicity.
Which is metaldehyde, I think.
Yeah, I can't remember.
That's the iron one.
No, I think metaldehyde's the original one, isn't it? It's the green one. I think I'd have to look it up. Did I Google, or is that cheating during one of these things?
No, I Google all the time. Please. It's interesting now. I don't remember anything because I can just look everything up so easily. But it's worth, if you are presented with someone that says my dog ate snail bait, it's worth making sure that they bring in the packet or a photo of the packet so that you can then cross-check, okay, is this something I can actually reverse?
I think it's the organophosphates and the metaldehydes cause like the trembling and twitching.
Great.
More.
Yeah. Excellent.
No, that's right. Metaldehyde is no specific antidote. Sorry, but it does cause the seizures and the muscle tremors.
Mm.
So what's the other one? I can't remember.
Or yeah, an OP of some kind, probably.
Mm.
So then other clinical relevance. Tell me what the mechanism of action of myasthenia gravis is.
Well, it's causing muscle flaccid paralysis. You can treat it not with atropine. You can treat it with, it's like desmopressin, isn't it? And I have to know what desmopressin is to think. It obviously affects one of the nerve receptors. I can't go any further than that.
Anybody else?
It's attacking the nicotinic receptors, so in the sympathetic, well, they're in both, but in the sympathetic nervous system needs them completely. So it causes the that loss of muscle tone.
Yep, excellent. So nicotinic, did you say? Did you say that word?
Nicotinic. What did I say?
Yeah.
Nicotine.
Nicotine. No, I think you said nicotinic. I just wanted to make sure because this is where the clinical relevance of understanding where are these receptors and what's their function. So they're both ACH receptors, right? But one's in the parasympathetic nervous system. They're the muscarinic ones. And then we've got the nicotinic ones in the, oh my God, what is the name of that nervous system? Skeletal muscle, neuromuscular junction. You know what I mean?
At the neuromuscular junction, yeah.
At the neuromuscular junction, let's say that. So the nicotinic ones are in there. So what drug do we use to manage myasthenia gravis sometimes?
Pyridostigmine.
Good. What does it do?
So with myasthenia gravis, your ACTH can still be released at your neuromuscular juncture. It goes across your synaptic cleft, and then because your own antibodies have destroyed your receptors on the other side, you've got reduced receptor capacity. So that drug stops the breakdown of acetylcholine, so that you get a really high concentration within the synaptic cleft to hopefully then bind to whichever receptors you do have left.
And
So
because
is that one an acetylcholinesterase inhibitor? Is that
yes, excellent. That's exactly what that is. Yes. So if we know that we've got two receptors that rely on acetylcholine, one's there, the muscarinic receptors are still there. The nicotinic receptors are the ones we're missing because of the autoimmune destruction of them. So if we then block acetylcholinesterase, what are the side effects of that medication going to be?
Oh, so you get SLUD. Like you get SLUD side effects.
Yes. All coming together.
Which we know because if you, yes, okay. Yes.
Yes, we see that. Yeah. Yeah.
Okay.
Excellent. Well done. As I'm testing myself, I'm like, God, can I remember this stuff?
So
Okay.
can you just rephrase that? What does she mean you get slug side effects?
Blood, salivation, lacrimation, urination, defecation. Okay. Yeah. So upregulation of the parasympathetic nervous system, because the acetylcholine and muscarinic receptors are working perfectly. There's still the same number of receptors there.
But you're suddenly flooding it with acetylcholine.
Exactly right. Okay. Yeah. Excellent. Okay, so let's talk about neurotransmitters quickly, other neurotransmitters. So we've talked about acetylcholine. What's another one? Noradrenaline, adrenaline. What receptors do they work on?
You said you did say it was at the second lot of receptors in the
postganglionic neuron.
Postganglionic neuron in the parasympathetic nervous system. No.
It is it's sympathetic nervous system.
Sympathetic. It's the first one you talked about.
Adrenaline, the fight flight one, right?
Yeah.
So those, they work on adrenoreceptors. There are heaps of adrenoreceptors, which are clinical targets for medications. What's some that we use regularly? What does dopamine do?
Increases blood pressure, so it obviously works on adrenoreceptors.
It does, yeah. So there's selective ones, the selective adrenoreceptor agonists, and then non-selective ones. Most of what we use now are selective. Like if we give adrenaline, it's going to work on everything, right?
Yeah.
If we give something like dopamine or dobutamine, they work more selectively on specific adrenoreceptors to elicit a more specific response. What's another one we use? For airway disease.
Terbutaline or that class.
Good. Excellent. What does it do?
I mean, dilate airways, hopefully.
Yeah.
I don't know.
Do you know which adrenoreceptor it's selective for?
I mean, I do, but can I bring it out of my head? No.
No, it's not right. So I actually am not 100% sure of the answer to this myself, but typically I think of alpha adrenoreceptors being in the blood vessels.
Respiratory tract. Oh, blood. Okay.
Being alpha, being more in like the bloodstream and managing blood pressure and stuff, and smooth muscle tone. Where beta receptors tend to be in the lungs and heart. And beta 1 is one of them, beta 2 is the other one. But many of the drugs that we use to dilate bronchi, which is one of the beta receptors, will also have the side effect of causing tachycardia. And many of the medications we use to increase heart rate, like adrenaline, noradrenaline, will also have the off-target effect of dilating bronchi and vasoconstriction, among many other things. So alpha and beta, I can't remember which one. It's beta 1 and beta 2, and they're in the lungs and the heart. If anyone remembers that or wants to Google, let me know. But that's kind of sympathetic nervous system in a nutshell. Those are really kind of fight or flight responses. So what's... No, I don't want to go into it. We could talk about this for hours. It's so interesting. Tell us about more neurotransmitters that are, so we've talked about the ones that are in the kind of lower motor neuron and parasympathetic system. What about the neurotransmitters that are central, that are relevant for us clinically with seizure disorders, sedation, effects of sedation and stuff?
GABA?
Yeah, great. What does GABA do?
It's your primary inhibitory neurotransmitter centrally.
Excellent. So we tend to talk with the peripheral nervous system about predominantly excitatory neurotransmitters because they're the ones that elicit a response. But actually centrally, we're trying to walk a very fine balance between inhibition and excitation. So the inhibitory neurotransmitters are just as important as the excitatory neurotransmitters in the brain. And what happens when we've got an excess of excitatory neurotransmitters or a like hyperpolarized state?
The seizures are more likely.
Exactly right. Yeah. So the inhibitory neurotransmitters, very useful therapeutic target for both seizures and sedation. So if we increase inhibition in the brain, then we decrease alertness, activity. If we decrease inhibition in the brain, and there's many medications and things that do that as well, or toxins that do that, then we're going to tend towards an excitatory state and increase the risk of seizures. So GABA is, does anybody know, again, I love physiology. Does anybody know how GABA causes inhibition? Or how any of the inhibitory ones cause inhibition?
I'm assuming they work at some receptor, but I don't know which receptor they work at.
No, fortunately, it's kind of like the GABA receptor, or it's
okay.
They make it easy. Yeah.
Yeah.
But the actual way, and this is really important because this is across like just physiology kind of 101. It's not specific to neurons, it's in muscles and stuff as well. What actually happens?
They preferentially take up those receptors, something like that.
So the receptor gets activated, and what happens to the charge in the cell to make it less likely to be excited?
It doesn't reach threshold, so it must drop, become more negative, I'd say.
Yes, great.
No,
so it increases, so it makes the inside of the cell more negative than it would be otherwise. So if you guys are, oh, it's time for arts and crafts. Lucky. Everybody. Oh, I hope my mouse went. There we go. My mouse battery went flat this morning. It's like, what's going on? Why can't I get into my computer? But it was because the mouse was dead. Okay. I hope I get this right now. Okay, so we're going to have 0 here. And this is positive charge. And this is negative 70. Negative 90. Okay, so most of the time we want our cells to be sitting around about negative 70 charge wise. And then when we have an excitatory neurotransmitter trigger a receptor, we get an influx of sodium typically, which increases the charge inside of the cell because sodium is positive, right?
Yep.
And then we hit this threshold line where all of our sodium, so a few sodium channels open in response to the neurotransmitter, and then we hit this line where all of our sodium channels open because they're voltage gated, so we get to that potential, and then all of those neurotransmitters open, and sodium floods, sorry, not neurotransmitters, all of those sodium channels open, and the sodium floods in and makes the cell really positive, and the result is depolarization. So in a nerve, that's then going to result in transmission of a signal through the postganglionic nerve. If that's where we're up to, it's going to result in excitation of a muscle, if that's where we're up to. So just physiology wise, this is just how action potentials are generated, essentially. So if we're starting down here, it takes a lot more excitatory neurotransmission to get to our threshold, doesn't it?
Yep.
So an inhibitory neurotransmitter results in opening of chloride channels to allow chloride into the cells. So what's the charge on chloride?
Negative.
Negative, exactly.
Negative, yeah.
So if we've got more chloride in the cells because there's more chloride channels open because of those inhibitory neurotransmitters, we're going to be sitting at a lower baseline, and therefore it's going to take more excitation to get to that threshold potential. So if we talk about that in terms of seizures rather than just an action potential, we want to inhibit seizures. We want all of our neurotransmitter or all of our cells sitting at as unexcited as possible. So we want all of them sitting at negative 90. What's the downside of it sitting lower than that, like the normal threshold, the normal resting potential?
Well, it dulls your senses because
Yes.
you're not going to react to anything, yeah.
Exactly right. Yeah. So this is something that we utilize when we're giving sedation, isn't it?
Yep.
Yeah, we're decreasing excitation and we're decreasing the level of mentation as a result of it. So there's a downside. It's not like we can just do this all the time, but this is why phenobarbital causes dullness. Phenobarbital potentiates GABA. So it makes everything more negative in the brain, makes them less risk for seizures, and their alertness level does tend to correct over time, but they're always going to be a little bit duller because we've decreased that resting potential in their brain. Make sense?
Yeah.
How good's physiology?
Yeah. It's good. It's good. Just complicated.
It's very complicated. Okay. There's one other inhibitory neurotransmitter which is worth knowing about. It's predominantly in the brain stem rather than forebrain. And spinal cord, I should say.
Did you say an inhibitory? Sorry, Anna.
Mm-hmm. Yeah. Should I tell you?
Yes.
Yeah. It's glycine. So tell me, what does tetanus do?
Increases muscle tone to the point of, rigidity.
Good. How?
So, good question. Clearly, it has something to do with glycine. So you were going the other way around. You're not dulling things down, but you're not causing. Well, you can cause seizures with tetanus. So it's causing opening of the sodium channels.
Mm-hmm.
Yes.
It actually blocks glycine and GABA.
Okay.
So it blocks
the
the
tetanus
two
toxin blocks it.
Yes. Yeah. So we lose inhibition just from that normal, like, homeostatic kind of balance. So that means that overall we're more excited, and we'll see that peripherally initially, and then we'll see that centrally as the disease progresses. So glycine in the spinal cord, GABA in the central nervous system, in the brain, forebrain. Excellent. Okay, so we've got the central inhibitory ones. What are the primary excitatory ones?
Glutamate.
Great. Now, glutamate is a little bit more complicated because it's not just like the GABA acts on the GABA receptor. Glutamate acts on a few different receptors to have a few different effects. So more similar to the nicotinic muscarinic kind of ACH response. Do you know anything about the receptors it acts on, or the one that is our main therapeutic target?
No. What?
No.
Tell me about NMDA receptors.
Oh,
what do they
yes,
do?
it's where like ketamine and amantadine can act.
Right.
Yeah.
And to what effect?
To block glutamate. Oh, yes, this is why people are using ketamine now in like prolonged seizures, because actually
yes.
GABA gets once you're anti-seizure GABAs, you just stop listening to it, and then glutamate's upregulated. Yes, that makes sense. So you can use them
for inhibiting glutamate.
Yeah.
Great, excellent. So there are a few different types of receptors. The AMPA are the other ones, but the NMDA are by far the most relevant, just from a clinical perspective.
Pain and like analgesia and sedation. I guess, yeah.
Excellent. And interesting, paracetamol has acts on NMDA as well, which is surprising because we always thought of it as essentially acting like perception of pain rather than source of pain, but actually it does downregulate NMDA activation. Excellent. Okay, let's talk about disorders of different sections of the nervous system now, if everybody's happy with the physiology we've covered. So So,
Well, it's just inspiring me to go back and read more because I'm just really realizing how little I know.
do you know what? So much of it's not like you don't need to know that stuff on a daily basis.
No,
But where
no.
I find it helps me is as new drugs and stuff come out, if I'm like, oh, I know exactly what receptor that's acting on and how
Yeah,
I can predict how that's maybe going to interact with that other medication or something like that. So
yeah, yeah.
for a medicine specialist, I feel like it's like I'm so glad
Useful.
that I had to sit my
Yeah.
fellowship exams twice to learn this stuff.
Reinforced it
So
all.
relieved.
Yeah, yeah,
But I do think it's valuable. It's valuable to
yeah.
learn if you're interested in that stuff. Okay, tell me about disorders of the autonomic nervous system.
Um, this is where I start to get very confused still. Autonomic versus,
Autonomic, I think of autonomic as automatic. It's the stuff that we've got no
okay.
control over. So it's like
So versus,
parasympathetic, sympathetic, basically.
but is it a different name? It's not a different name for the same thing. So it is. So it is. So parasympathetic and sympathetic are all autonomic.
Yes, exactly.
Yeah,
Yeah.
yeah. Okay. So
Um,
what was your question again? Tell us about the autonomic nervous system, or tell us
well,
about.
let's talk about disorders that impact the autonomic nervous system.
I guess myasthenia gravis would be one.
I would argue that's actually neuromuscular. So
Yeah.
it's probably sitting less under that automatic kind of function disorders. There's the reason I raise this because there's actually very few disorders of the autonomic nervous system. It's more of a target for our therapeutics, like as far as managing heart rate, blood pressure, and stuff like that.
Mhm.
But there's one in particular that is emerging in cats in England.
The only one I know of is dysautonomia, but I'm not going to pretend that I have any understanding of what it
That
actually is.
name is very descriptive.
Right.
Yeah.
Dysfunction of the autonomic nervous system, basically.
Yes.
Okay.
So
And that, sorry, that is what's happening in England, is it?
yes, and I don't think
Yeah.
they know why yet. I'll be very interested to see how that pans out, and I haven't been following it very closely to be honest, so it might have panned out already. But there was just a big case series of cats with dysautonomia, which hadn't been reported for a long time. But essentially, it's dysfunction of the parasympathetic nervous system. So they get constipation, dysuria.
Megaesophagus? It's just always on my list for megaesophagus, is it? Or am I making that up?
Megaesophagus, did you say? Yes. Yep.
Yeah.
Absolutely.
Yeah.
Yep.
That's the only reason I know it.
Smooth muscle tone. Because that's all parasympathetic nervous system is digestion and smooth muscle. Yeah.
Do they think it's an autoimmune, like immune mediated against nerves,
Just ask.
or like an infectious trigger? Okay. Oh, it doesn't matter.
I don't actually know. I'd be very interested if someone wants to do a little Google.
Is this what people call key Gascal? Is that what you mean? Is that
exactly right?
okay?
Yeah. Yeah.
Wait,
Do you
what's
remember
it,
that?
what's it called, Helen?
I just remember studying it. I don't remember anything about that. Key Gascal syndrome.
Key Gascal. I've never heard of it.
Because then it was like, oh, maybe it's wildly underdiagnosed, and I was like, oh, maybe that's what.
Yeah. So they get mydriasis with absent PLRs, dry nose and mucous membranes, third eyelid protrusion, dysphagia, regurgitation, megaesophagus, constipation, bradycardia, and urinary and fecal retention. And the name of that
Opposite of stud.
just if you key Gascal, I don't know how you say it. So there's some environmental trigger for it, essentially. There was a spike in the 80s in the UK in dogs, and I believe there's been a spike in cats recently. But yeah, worth having in the back of your mind. I mentioned there third eyelid prolapse. What would cause that, and how does that tie into another syndrome which is associated with part of the autonomic nervous system?
Well, Horner's syndrome, you get third eyelid
Very
prolapse.
good. Excellent. What is Horner's?
Well,
It's a syndrome of a pattern of clinical signs of some pathology is affecting the parasympathetic supply to one eye. I think that's how I would very briefly.
Excellent. And so what if parasympathetic nervous system is working well in the eye, what are its functions?
Constriction,
Constrict the pupil.
tear production,
Mm-hmm.
allow the
tone the
relax.
muscles in the eye.
Mm-hmm. Good. Yeah. So then Horner syndrome, what we've got prolapse of the third eyelid. What else?
Dilated pupil.
You get
No.
strabismus. You get nystagmus, and you get sinking of the eye.
Shouldn't
Which
get
is probably what
nystagmus, 'cause
causes.
that's vestibular, but certainly strabismus.
Yeah,
And that sinking of the eye is why the third eyelid prolapses. So you're exactly right.
prolapses.
Yeah, exactly. So I actually think it's meiosis.
Meiosis,
it
yeah.
is.
Yeah, rather than, oh, look. I didn't do that on purpose, but I was talking about pupils. Yeah, so it's essentially we've got a loss of sympathetic tone and therefore unopposed parasympathetic tone to the eye.
Okay.
So we've got an excess of relaxation in the eye, if that makes sense. And when we've got our sympathetic nervous system activated, we want to have our pupils dilated, so all the light comes in, we're not missing anything. So when we've got an excess of parasympathetic tone, our pupils constrict down. We don't really mind if we miss stuff because we're really relaxed.
Yeah.
Excellent. Good. So they're the two kind of disorders that I would say are relevant autonomic nervous system wise. And then the rest of the sort of, I guess, exam questions I'd ask around that would definitely be on therapeutic targets. Like, why would I use a certain blood pressure medication over another with a certain underlying condition or something like that? Is probably something that I'd throw in an exam. We're going to do a big session on seizures, so I don't want to go too much into disorders like seizure disorders, if that's all right, just because there's so many kind of clinical guidelines now around seizure management, chronic and acute. Let's talk more about, we are also going to do a vestibular session, so let's talk more about how we localize spinal lesions, because that's not really my field typically. Okay, so if you've got a lesion in C1 to 5, cervical neurolocalization, what are your lower motor neuron reflexes likely to be like in both pelvic and thoracic limbs?
You're going to get increased tonicity because you haven't got any damping effect from above. So basically, you've got hyperreflexic reflexes in all hind limbs.
Excellent. Yeah.
So you actually have upper motor neuron signs in all the limbs, right?
Yeah, exactly.
It's just about recognizing that but anyway.
I know. And particularly in the thoracic limbs, I just think it's so subjective.
Yeah,
Lower motor
Yes,
neuron.
because they're
Especially if
hard to get in the first place.
Yeah.
They've
The
got
reflexes
paresis
are
as
hard to
well, and you're like, how do you tell the difference?
Yes, exactly. So our lower motor neuron, we're going to say normal to increased. Do I need to go through the reflex arc, or are we comfortable that that's a localized pathway that doesn't require any transmission up the spinal cord?
You
Yeah.
don't need to go through.
Okay. Excellent. So perfect. So we're going to have normal to increased lower motor neuron signs for our C1 to C5 lesion. What is going to allow us to say this is a cervical problem rather than a brain problem?
Like your cranial nerves, so you check all your cranial nerves out to see if they are all within normal limits, I guess.
Good. Yeah.
Mentation should be normal.
Mentation, excellent. Good. Yeah.
They're probably going to have a sore neck.
Yes, I was going to say, it might be a
Pain,
clinical sign
exactly.
associated with
Yeah.
pain. Yeah.
Exactly. Yeah. So these dogs I always talk about dogs because cats don't tell you when they've got sore necks. But I just watch them move around the consult room, and I'm watching them like most dogs will be looking around, for their owner. Dogs with sore necks will be doing smaller movements with their head, moving their body, taking smaller steps sometimes because they don't want to kind of stride around because they're tight, sore. So I'm looking for like subtle signs that their neck might be sore, and also subtle signs that their mentation might be reduced or that they might be circling a little bit. So say then, what other elements of your neuro exam are you going to be interested in?
As to which side might be more affected than the other side.
And how are you going to determine that with a C1 to 5 lesion?
I mean, other than pain on whichever side, it should be on the ipsilateral side. I mean, you could start doing all your hopping and skipping.
Yeah.
I forget all the names for the different tests, but lifting up one side, lifting up the other side, strength.
Yeah. It's
proprioception.
Proprioception, exactly.
Yeah.
So all of the sort of hopping, skipping, placing tests are assessing sensation, going up through that affected section of the spinal cord to the brain, changing sides, message being sent back to place or move that limb. So we've got not a local reflex arc, we've got a pathway that involves lower and upper motor neurons, sensory and lower motor neuron, upper and lower motor. So we're assessing a really long pathway, and this is the section we're really interested in when we're suspicious of neck pain. That will help us to lateralize, and it will also, in some situations, help us to determine central or spinal cord or forebrain or spinal cord. How will it help us to determine that?
So forebrain is conscious. So do they? I mean, if you're looking about pain, do they react to what you're doing? I mean, is that what you're getting at? So
it's
no.
actually it's actually more lateralization. So if I've got a cervical lesion that's lateralized and I've got absent proprioception on my left long tract, so both thoracic and pelvic limb have reduced proprioception, and I've got a patient with neck pain. So then I'm going to say, so then I'm localizing things from here up, right? If I've got absence of proprioception down that side. If it's a forebrain lesion, which side is the lesion on?
The right.
Yes. If it's a neck lesion, which side is the lesion on? Yeah.
On the left, yeah.
Yeah, exactly. So then assessing pain responses to flexion, lateralization, where there's no other kind of localizing signs in the forebrain, or having watched them maneuver a consult room and noticed that they can't turn to the left, I'm going to go, okay, it's probably actually a forebrain lesion. Or that they've got subtle slow circling to the right. Good. Okay, what about if our lesion is C6T2? Sometimes they can move their neck really well. It's really annoying. Like they're not sore when you examine them.
And
But
I feel like working out which side of the neck is sore that's really hard.
it's really hard. The only thing is that lateral flexion is the only like way that I
But I
would.
feel like sometimes they can be like it is quite a lateralized lesion, but they'll be sore just touching their neck, they're sore. So
Yeah, they can
yeah.
become hyperesthetic, don't they?
Absolutely,
Yeah.
and they're like, get away from my neck. I'm going to react. Whichever way you turned me first, I'm now going to react more.
Mm.
Yeah.
Let's go back a step. What with the
Yeah.
last one? Why did you say it's a forebrain lesion? Are you saying because it has no pain in its neck, so it must be a right forebrain lesion? What happens if you just have and you were trying to determine whether how it was a forebrain lesion or a neck lesion? And I'm not sure, I missed a step there.
Um. So presence of pain in the neck with no change in mentation, no circling or other signs localizing to forebrain.
So that's a neck lesion.
Yes, neck lesion, exactly.
Yeah. But
Yeah,
no pain and circling, then you've got a forebrain lesion, but it's on the right
exactly.
hand side. Yeah.
But it's right hand side of the
Yeah.
lesion. Yeah,
Yeah. No,
exactly.
I
So
get
what
the
I've done,
contralateral thing,
yes,
the
exactly.
crossover.
So
Yeah.
yeah, most of the nerves cross over in the brainstem
Yeah.
or midbrain.
Just to
So
confuse us. Yeah.
yeah, I know, but it does sometimes help us to localize. So
Okay.
yeah, if I'm sort of if like I would, often you look at a dog and they're not really overtly circling, their mentation's like probably appropriate for a 13-year-old or whatever it might be. Um, sometimes I'm like, oh, it's probably not forebrain, but then I get long track signs. I'm like, oh dear, yeah.
Okay.
So sometimes it
Sorry
just
to
helps
interrupt.
me form a bit more of a picture of where I want to scan in my
Yeah.
which section.
Yeah. Okay.
Okay, so C6T2, why is that such a small section and why does it help us to localize?
They're the
What
nerves that
changes?
supply the front leg motor function.
Yeah, yeah, exactly. So it's where all the thoracic limb, lower motor neuron nerve roots come out. So what if I have a C6T2 lesion, what would be different in my neuro exam from our C1, C5?
So
You'd have poor reflexes,
yeah, the
even though
front
front limbs.
have reduced lower motor neuron function.
Excellent. Also really hard to make a call on in my experience.
Mm.
So often we end up saying C1, T2 because we can't. I'm not 100% sure they might be a little bit reduced.
Localize.
Let's scan a little bit more. Like just extend that out.
All right, hold on.
Yes. There's a specific clinical syndrome that sometimes happens in dogs with syringomyelia, where the syrinx gets so big in that section that they lose motor function in their forelimbs, but their hind limbs are preserved.
Oh, cool.
But just put that on your radar because the syrinx comes from the middle, whereas most other lesions come from ventrally, like the discs and stuff. So it puts pressure on a different section of the spinal cord. So that might be an interesting presentation if you've got any syringomyelia style dogs. What I feel like you guys have got a really good grasp on this, so I don't want to go to like three more minutes. What do we want to spend time on?
I think that's good to clarify. Like C1, C5, the legs are upper. C6, T2, the forelimbs are lower, the hind limbs are upper. 3, L3, the forelimbs can be normal, the hind limbs can be upper. L4, L4, S2 or 3, forelimbs are going to be normal, hind limbs are going to be lower. Like I feel like that helped me when I memorized that.
And
Which is
so
a
I
bit
find the thing that always scares me, so how do you differentiate between lower motor neuron signs, say in the hind legs from a spinal thing, versus like a generalized lower motor neuron disorder.
I mean, like tick paralysis or something like that.
Oh, yeah, luckily we don't have ticks here. So yes, but yes, exactly. That's exactly what I mean. Yes. Or
Yeah.
myasthenia gravis or a weird junctionopathy or something. Like how do I know?
How? I think that if you've got lower motor neuron signs, then you need further testing to differentiate between L3, S3 or like motor unit. So like there's no way on examination neurolocalization wise you've like it localizes to the lower motor neuron. So where you might be able to say it's probably still a localized disease process in that lower motor neuron of the hind limbs is whether the forelimbs were affected, whether there's any history of like changes in swallow or megaesophagus type signs. There might be other kind of markers of like what's that, polyradicular neuritis or something like that, because it's always the pelvic limbs that go first. And often I've said to clients, like, they don't seem painful, they're not at risk, they're not regurgitating, vomiting, aspirating everywhere. I'm going to see what's happening tomorrow or 2 days' time, because then I'm going to be able to decide what tests to do next better, if that makes sense. So I wouldn't be shy about saying, I've got one data point here. If this is a progressive thing over the next 24, 48 hours, then it's more likely to be polyradicular neuritis, where then the forelimbs are affected and then it's obvious and it's clearly lower motor neuron. Or now we've got some lumbar spinal pain or something else to help us localize it. And really, like, there's no conditions where the animals, well, like, obviously if they do have like more generalized like megaesophagus kind of signs, like if it's myasthenia gravis, then I'm not going to just wait. But there's not that many like where it's subtle like that can't just wait a couple more days and help me something come out, sort of thing. You know what I mean?
Yeah.
Yeah, because are a lot of those diseases that you're referring to, Simone, like, would most lower motor neuron diseases and that aren't spinal be quite generalized? Or can you definitely get? Because I feel like the other things
Generalized,
are pretty
but
rare.
they start in the back legs.
Yeah.
Like
I see. Yeah.
Yeah. So even if it's like, a really chronic peripheral neuropathy, if it's something that's affecting like myasthenia gravis, so long nerves are affected first by any neuropathy process. So it's always back legs first. And big muscle groups are affected more severely than small for neuromuscular diseases. So the glutes and thighs, which carry a lot of the strength, are going to be affected, where like the shoulder girdle, like they can kind of just sink into the shoulders and sit in the sling of the pectoral muscles and just take slightly smaller steps. It can be very subtle in the thoracic limbs, whereas the hind limbs, they use those to get up.
And then like cranial nerves, like even more subtle, right? Like they have to be like so affected to be able to appreciate changes there. In my experience, like
Sure.
like
Yeah.
how many times do you have to hit the middle of their eye until their palpebral nerve is, the palpebral reflex is not happening. Like I don't know, I find it, yeah.
They're so subjective, and that's where I just give myself another day or two. Something will come to a head. I word it much more carefully, typically, than that to clients. Sink or swim, puppy.
Yeah.
All right, we better wrap up. That was fun. Thanks, everyone.
Okay. Thanks so much.
Thanks,
Nice
Tana.
to see you, Jill.
Bye.
Thanks for coming.
That's good. Bye.
Bye.
Bye.